actually. Yeah, absolutely. Good idea. All right, thanks. Bye.
Everybody else can do inches, so how come we do that? Which means I'll never ever get accuracy. Unless they go down. Well, once they get this canal system up and functional, if it's going to work the way they want it to going to work this morning, then you'll never have to evacuate again.
What are your 2 billion drivers? Okay. Customer service here, right? It's like,
They're going to fix the dams. Have a plan to lower the water.
Monitor there's no monitor.
All right. Well, let's get going here.
Do you buy it?
Yeah.
All right. Call to order approval of the minutes from June. March 20th. Any additions, comments, corrections?
Thank you very much.
Hearing none, minutes approved. New business confirmation of the following issues. This is really just informational, I guess.
Right. The what was approved by the REMAC doctors from my email consensus, the new medical director for Franklin Emergency Squad, and requests from the following agencies to begin intranasal naloxone: Cleversville Fire Department, Flag Creek Emergency Squad, West Exeter First Responders, Rhode Island Volunteer Ambulance, and Speculative Volunteer Ambulance. Requests were also received from JVAC, Northampton, Paseco, Wells, and Morehouse, pending written approval of their agency medical directors. And the REMAC physicians signed off on all of that via email, since we did not have a quorum at our May meeting. And then they also agreed to the only out-of-state emergency squad can begin use of glucometry. So we're just asking that you, since we have an official meeting now, that the doctors confirm that this is as they desire.
Any comments from anybody? You can't have enough naloxone these days. Is naloxone a controlled substance the way the DEA?
No,
It's an antidote, but I mean, is it also categorized as a controlled substance?
No, it's not. No.
Good.
Not yet, right?
All right, new issues for today.
Okay. Franklin and Scowright have requested approval of the REMAC to begin use of intranasal Narcan, and they have submitted letters signed by their agency medical director and also by their captains.
Okay, is this still part of the pilot project of intranasal Narcan, or is that the lid came off on that?
I believe the pilot program is ended now.
Okay,
yeah.
so we're into
it's ended, so it's just
the real deal.
Okay.
They have to go through the REMAC for approval.
Okay. All right. All those in favor? Aye. Any opposed? Good.
It should be noted though, they're working on getting a new medical director verification form online. Or you know how you usually check FDL, buterol, blood glucometry? There's now going to be the
Those would be under that same sort of grouping?
Yes.
Okay.
That makes sense.
So you may want to have the agencies watch for it and then just re-sign it to cover it.
Okay. Approval or consideration of Schoharie County Critical Care Team to begin NF5 training.
This was, information on this was sent around by email to the REMAC physicians, and obviously their feedback was solicited.
And so, discussion.
Yeah, I have some great hesitation with that as far as numbers go, and now with CPAP. I mean, I don't intubate a third the number of patients that I used to intubate because of these modalities. And I have a lot of experience doing this stuff. I don't see how in the field, you know, judgment-wise, that comes into play. And then I'd like to hear about numbers of people that require intubation. When they started doing this up in Remo, a lot of patients were extubated on arrival in the emergency department, so I really have hesitation to approve something like this on a small scale, unless their volumes can support it. And if they're So, I don't know what the feeling is, but that's my input.
Any other comments?
Can I speak on that?
Sure.
Okay. No, our agency is the main provider for ALS in the county. We do approximately 1,500 calls a year. Of the 1,500 calls a year, probably less than 5% require intubation. That's including cardiac arrest. Just in the past month, we've had 3 cases where we could have used MFI. Just 2 days ago, we had one. A 19-year-old male was unconscious, unresponsive, and we could not manage his airway. Having a hard time managing his airway. We used etomidate, that didn't work. He just kept clamping down. We couldn't intubate him. We got into Ellis with him, and they did RSI him and intubate him.
Was he hypoxic en route?
Borderline. He was 94 and 95%.
Okay, so that's not hypoxic, okay.
No.
So what, all right, so that's one case. What's the national average for people requiring intubation? Is 5% that seems pretty high. Does anyone know that?
I think you said that most of those are cardiac arrests, right?
Right.
So they don't require.
Yeah, I think some caution is warranted. The single biggest threat, I mean, the first job of all healthcare providers is to do no harm. And these battery of medications has the potential to do in a big way, like stop breathing. And so I share Dr. Fisher's concerns about numbers, about indications. If cases are going to be referenced, I think we should review those. You know, if you saw cases that you thought it was indicated, why don't you have your medical director come here and make a case. It's a skill. It's not so much the drugs. The drugs are significant drugs. Succinylcholine causes complete paralysis. So at that time of injection, the person stops being able to breathe for themselves. That is the single biggest critical cognitive decision that we can make in all of airway. You're going to stop somebody's ability to breathe, or even attempt to breathe. It's a huge decision. So how do you, the algorithm to get there is the most important part. It's not about the drug, it's about how do you get to that decision point. And what I just heard doesn't convince me that there's a case. If you give etomidate to somebody, you're sedating them. If this person was unresponsive, they didn't require etomidate.
I just did the numbers real quick. I mean, we do MFIs. 0.4% of all of our patients actually receive MFI. We're a fairly large agency, 10,000 plus calls a year. 0.4% actually get MFI. We also have a very, very strict training program. I mean, our medics are in there quarterly, doing tubes, getting quizzed, going through every 6 months. It's a refresher for them. I would be curious to know what plans you have in place. It requires 2 of our medics. What plans are in place if you're responding in a single fly car system? Where is that second medic coming from?
We've addressed that in our plan. Our plan says that we will have 2 medics there to do it, to do the MFI. As far as training, again, Scott wrote, I believe it was quarterly training as well. Right now we have 3 medics that are already MFI certified. They work with other agencies. One works with LifeNet. All of our medics are experienced medics. They all have had successful intubations, very few, if any, non-successful intubations. With our agency, to go you know, within protocols, we have to transport to an appropriate agency. For us, an appropriate agency is an average of 45 minutes away. So if we have any of the serious traumas, we're either going to be going to Cooperstown or Albany Med. Depending where in the county, it could be upwards of an hour transport time. Average, like I said, is about 45 minutes.
How often do you call a helicopter?
As needed. Again, we have to justify the use of a helicopter. We called, I don't know, in the last month, I think we've called 3 times for helicopter.
I think it would be good to do some kind of like needs assessment and frequency use. The issue of providers who are able to work for more than one agency, I think that's an interesting question. You know, so a provider might have like a ton of experience in agency A, and then their agency B may be rural, less volume, and yet the skill set would be useful. So is there a way to sort of take the totality of that and consider, you know, if their main agency is busy, frequent use of MFI, indications, et cetera, and all the rigor that goes with a program like AVAC or LifeNet, maybe that would be a consideration. So I think we need to hear more from the county in terms of scenarios, volumes, actual cases, I think would be useful. And then an impassioned medical director would be required, or at least a strong statement from the medical director about the importance of that.
I just like to say that we provide services to Montgomery County totally, and I think they're on the right track, and I do think that they have absolute need to have that skill set. And I think that, giving them the opportunity to do something like that and provide that level of care, because that county is even more rural than our county, and their transport times are much greater.
Right.
And, with the level of experience that 3 out of 4 or 5 of their providers have, they are already on the right track. It's just a matter of fine-tuning their program and like you said, getting their medical director deeply involved and things like that. So I think there's a definite need in that county for that program.
Okay.
I agree. I'm a RSI credentialed paramedic with Albany County Sheriff's, and it serves a similar population. And the only thing I'd say is just caution looking at numbers, because really, as both you guys highlighted, it's more about the approach to the airway and decision making than it is just a straight intubation. Intubation is a straightforward skill. It's more about knowing when to do it, what to do it.
Right. I think for any and I mentioned the agency A, agency B scenario because the numbers per individual may be significantly different depending on which sphere you're looking within. Right. So it's like surgeons that operate, right? If they do X number of procedures, they do better than if they do fewer. But they might operate at like 5 hospitals, so you have to look at the totality of their work. So I think we're a little bit. So it's a good discussion. Yeah.
And I think Mary, you asked how often they call the helicopter. If the helicopter were 100% guaranteed be there every time, then it might not be as pressing. However, we all know that the weather and the fog and the this and the that prevents that being a 100% constant resource. So I think putting the resource into the hands of the people who have to figure out how to manage it when they can't get the help that they need. And you've got such a limited group of people that you're not trying to spread this over 40 people trying to learn it. You've got a good controlled group.
I think the other thing for initiating a program is the proximity of the medical director to the agency. So the receiving hospital for these patients is predominantly Obelskill, as I mentioned.
Not for trauma, the Albany.
Any of the more serious ones, we go to the larger hospitals.
I would think that if you had an RSI, you would almost never go to Cobblestone.
So we would need a medical director from the likely receiving hospitals for these patients, because it's, you know, the difficulty of trying to get QI data out of hospitals. So some congruence between the agency and the medical director for sort of close supervision of documentation and quality. What happened in the ER, was he extubated? You know, that sort of data seeking would be essential part.
The one last thing that I'd like to say about this whole thing is that over the years, a lot of things have changed with intubation failures by use of video laryngoscopes, which is basically what we use, air track devices or King Vision, and we really do attribute our success rate to, you know, the accuracy of these devices, and our failure rate is slim to none on any of our intubations, RSI or cardiac arrest. So, you know, at the county level with a small group of people, properly trained and with the right equipment, not spreading this program through all the small agencies of Schoharie County, but keeping it at the level of the county coordinators. I mean, you know, it's probably a viable option.
Do you guys have any video laryngoscopes?
No.
I'll throw one more pertinent fact out there. It's not a set in stone fact, but sitting and working with the protocol committee, I don't know how many other people here are involved in it, there's real discussion about the physicians and the committee removing nasal and digital intubation from a skill set. If you remove nasal and digital intubation, now you have no way to intubate the patient other than RSI in certain cases.
Well, the other thing that our protocols allow for is intubation with etomidate and Versed. And a perfect example is just 3 days ago, we did an RSI intubation on a severe trauma patient and pushed the etomidate in the jaw locked. So,
Right.
you know, we needed the succinylcholine to loosen the jaw to complete the intubation. So,
Yep.
just food for thought.
Yeah.
Throw my 2 cents in.
There is a, you know, there's a Ron Walls, who's sort of like the airway guru in emergency medicine, runs a great course, difficult airway. And there's an EMS version of that. You know, so I think if I was the medical director, I would strongly consider that being a requirement. But anyway, any other discussion about this?
Representing rural metro and the other agency that provides ALS in that county, my concern is if you have to have 2 paramedics there, there's generally one on. It's such a vast area. Maybe a cooperative, some sort of cooperation between our agency and theirs could allow to get 2 medics on site to do this.
So mutual aid.
Yeah.
What we were gonna do is simultaneous dispatch for the second medic, because whoever, there's primarily one on, and just, you know, like Wilton does a all call for the second medic. So there's 4 of us, that's how we would incorporate, it's all incorporated in the plan. I got a copy of the plan and everything.
Okay.
And I can attest to the Saratoga County plan basis. I am an MFI provider in Wilton, Monroe, and Schuylerville. Is interagency operability makes the process a lot easier, knowing that you're going to have additional resources coming from at least one other agency, not, you know, on top of your agency. And our success rates using video laryngoscopy and having an active medical director, part of Saratoga Hospital with the affiliation to get the information from Multi-Med, our data sets up there are phenomenal for what we can get for feedback, success rates. It's a data-driven system there. It's all electronic charting. Everything is there for.
Are you guys electronic?
Yes. And so your feedback there is almost immediate. I mean, we go as far as adding the video of the laryngoscopy to the chart.
Yeah.
And that's part of the QI process as well, is actually watching the intubation with the chart.
Right. What would be the feasibility, you know, so you're talking about sort of mutual aid for MFI with medics across agencies?
Well, you need...
No, I'm not asking you, I'm asking
Okay,
the group. What's the feasibility of doing training together so that, you know, the index cases is the first time you shook hands over a patient about how to do MFI?
I would train simultaneously as
Yeah,
a group that.
A team of medics for
Yes.
that purpose.
I mean, our agency has primarily the same group of medics who work in Schoharie County, but others fill in and they would be part of the training. And I think college is a great resource for us to train right there locally.
We do the course every year with our paramedic program, actually, so it wouldn't be hard to incorporate other people into it.
Right. So let's table the discussion, and does anybody else have any more? I don't think we can decide today. I think we need a little bit more information, background. I haven't seen the plan. Yeah, all those in favor? No. So we'll try to back up a little bit, get some more data and some information. And so you've heard the concerns and some of the suggestions. And Howard, it would be a useful resource to sort of, he knows the county, the program is located in Tulsa. All right, well, thanks for the discussion. I think we'll table it for now as a decision, then bring it back next REMAC or sooner if we have. All right, next issue.
The question raised about total quantity of midazolam to be carried. On April 11th, I got an email from a paramedic who works with JVAC, the Johnstown Ambulance, and he said, our med formulary on page 79 shows that Versed comes in 5 milligram units. We should have a minimum of 20. We, including all of us getting NOx from NLH, Nathan Latour Hospital, are only allowed 2 milligram units and can only get a 10 milligram total. That means if we use Versed just once, we're out of service, and it takes 3 vials to attain 5 milligram, wasting 1. I think we need to address this as a region. Thank you. So I'm bringing this up just for discussion on the part of the doctors, and obviously input from everybody here. We are only carrying a maximum of 10 right now, and I remember we had a discussion late last year, I guess it was, on the bath salts issue, which seems to be becoming somewhat less of an issue, happily, around our state.
You moved on to heroin.
They got to heroin, yes, oh sure. I didn't say it went away, it's just more. But I remember the doctor saying that sometimes they use a great deal of midazolam in the ED to take care of an excited delirium patient. And we only carry 10 on the ambulances.
But our minimum number in our formulary is for 20. If you look at the formulary, it says midazolam 5 milligrams,
right.
Minimum number 4. That would be 20.
The reason many of our ambulances, if not all of them, carry 10 maximum is because the hospitals have it loaded that way, and that's what we get from them. So just a matter of discussion, nothing that needs to be...
So it's not a protocol or a formulary change,
It's a hospital to change.
It's a hospital deal.
Hospital
The
supply.
hospital supplier has to change.
Right.
But, I mean, our formulary allows for 20 milligrams to be carried in.
I guess the question, if I was the pharmacist, I'd say, how often do you exceed your supply?
So, how do we as a group here help the agency interact with the pharmacy?
Data, we're in the age of data-driven everything. So if I was a pharmacist, I'd want to know how often, a number of cases where midazolam is used where you don't have enough. If you do 100 midazolam cases and 2 were excited delirium and you went over, so it's 2%. Am I going to make a pharmacy change for the 2% of patients?
From my understanding, they do carry the 5 ml vials, or 5 milligram vials. The problem is it's issuing it. It's, I believe, what the problem has been through the pharmacist at Nathan Latour. So the biggest thing I think we need to try to work on as a group is getting that changed in the pharmacy. From my understanding, they carry the appropriate dose and concentration. What we need to be able to get, because you end up, just to do an intranasal Versed, you have to open 3 vials and waste half of one every time.
Yeah. It's an interesting, I think we've been here before where
I
we
think
talked
we
about...
had this conversation when the protocol switched, and basically what I think every agency was told is they needed to switch concentration. The protocol clearly outlines it's 5 milligrams at 1 ml. That's the way our formulary reads.
Right, and it has to be that way because of the intranasal version.
Right, so I'm not really sure where these 2 milligram vials are even coming into play when the agency should be carrying.
And I did call the the pharmacist yesterday. He was out of the office, is in today. And that's one thing I did want to address with him, is to make that change, because it specifically states in the formulary. It's not I don't believe an option whether or not it's statistically used more, but this is how we are told we have to carry it, and I believe our controlled substances, controlled substance plan
The plan is
outlined
supposed
how
to be written that way.
it's supposed to be written to
As we've
match the
discovered,
formula.
we've made them change their plans.
So, I mean, it's my responsibility to get our agency on board with the pharmacy and get that changed. And, you know, that's something that I tried to put in progress this week, but haven't had the opportunity to.
Yeah, well, there's at least 2 or 3 moving parts to this. One is that pharmacies are constantly going in and out of supply of either drugs, it's not available at all, or concentration is available. So there's sort of vendor dependence about what's available and its concentration. So that there may be factors that even they can't control about how they get midazolam delivered.
Because if you're,
And that's why we had to, you know, when we were like running into that issue of drugs becoming unavailable, we went through like, you know, option A, option B, option C. Can you remember the grid that we had? If not this, then that, then this, then a rubber mallet was the final thing. So I think that's one issue. The other issue is that I think the pharmacists, just like we try to grapple with, you know, one protocol across 2 regions, or actually many more than 2 regions.
6 now, I think.
The pharmacists they confront it as a one-off, right? So here comes GABAC, here comes CMT, here comes Rural Metro, here comes this agency, here comes that agency. And theoretically, it should be fairly simple because the protocol is pretty clear. But I don't think the pharmacies or the hospitals talk to each other about EMS. So, you know, I have a meeting coming up because somebody wants to talk about Narcan. The supply of, you know, the new demand for Narcan. It's like, you know, what's going on? I think they know what's going on, but I think that they're a little bit isolated in terms of what else is going on in the region. And I've often thought, I don't know if REMO does anything like this, but that there's got to be some kind of, if we had a sort of a parallel pharmacist council that was sort of parallel to EMS, so they could talk to each other about what they're doing for EMS, since they're all addressing the same protocol.
REMO has pharmacists who come in and lecture.
They've got a PharmD out of St. Peter's, I think.
Yeah,
right?
it's the
That's
one
where
who
it's from?
did the last CIU
That
update.
sits regularly in the MAC meetings even.
Yeah, well, that's different than I'm thinking more about their coordination, their boxes and how they're supplying.
I think everybody in Remo, all the hospital pharmacies have been fairly compliant with what EMS needs. You know, they carry fentanyl in multiple different forms, but they specifically get the fentanyl for EMS in a glass ampule.
Right.
All the morphine for EMS is separate. It's in, you know, 10-in-1 pre-filled syringes.
So is this
all the versions.
is this current discussion about one hospital?
That's how Saratoga Hospital operates, and that's how all the agencies around there, they coordinated with the hospital what EMS needs to fit their formulary, their protocol, their controlled substance plan. They complied and worked together. Here, we need to work with the pharmacy to get our controlled substance plan to meet what it says, our meds to meet the formulary, and the hospital to be able to stock us with the appropriate concentration dosage.
Maybe a solution. So are you talking about one hospital in this region?
That's just, you know, for each specific hospital, agency has the substance through that pharmacy. Right?
Right, but nobody else is bringing the issue, so is this?
No, Fox Hospital has, for Oneana and CMT, they don't use the concentrations that they do, but yet they supply ours and keep ours in their pharmacies, so that when we come and need to get it, they go to the EMS cupboard and pull it out.
Gus, this particular discussion was initiated, as I said, gentlemen from JVAC, and it had to do with Nathan Tour Hospital. And I have had discussions with the pharmacists there, and I'd be glad to have a further discussion with them, a further conversation.
I think what I would suggest is you give that pharmacist, director of pharmacy, a resource within REMO and just says this is how we do it, or within Fox, this is how we do it.
Okay.
So if they operate in isolation, or if they just move to the state, you know, and so that not only do they do the protocol, but they have to do the state. I think it'd be good to have a resource that's outside their world.
Fox was, when there were all these shortages, Fox was so good to us that they saved the concentration that we needed. It made them change it on the floors so that we had what we needed on the street side.
Good. I guess, unless the patients on the floor were sneezing at the
But, rather than make us try to relearn, they made their internal people relearn different concentrations and dosages and saved what doses they had for the ambulance.
Right, so there is no strong sentiment that we need a pharmacy coordinator, contact liaison. Maybe Fox should do it. We should just go to the Fox pharmacist and say, hey, I would like to be the regional pharmacist coordinator.
I'm sure Pat would be receptive to that.
The next item on the agenda is initiated in Fox Hospital, so possibly you might want to reserve your thought on that.
All right. Moving along, any further discussion about that topic? Have we resolved anything?
I will chat with Bob Stankus at Nathan Latour Hospital again and see what we come up with, and I'll let everybody be aware of it by email.
Hospitals are and pharmacists are understandably, anxious every time they see controlled substances going out the door. So I think some reassurance by talking to another pharmacist about what they do, how they control. The systems of control are got to be fairly similar since it's federally regulated.
I think also clinically we're doing a disservice. I mean, it has been shown data-wise that more than 1 milliliter injected up an air tends to run off. So you're probably not getting as good a therapeutic effect with using the 2 milliliter vials and using 2.5 of them, as opposed to the 5-to-1, which is 1 milliliter.
Yeah, I was, that one of my frustrations, I would say, through my entire career with, this isn't just EMS, it's just sort of medicine in general, but, so here we are discussing protocols and doses and use and things like that. We asked the question, all right, let's pull up all the uses of midazolam year to date, region-wide. Can't do it. Can we? Every instance of midazolam.
I can do it as an agency within 5 minutes.
Okay, so agencies are well empowered to do that, but the region is mostly volunteer. And so, you can see why pharmacists get anxious. Controlled substances going out, and nobody's monitoring its use or its use. On an individual case we are, but if we ask as a region, because this should come up at protocol meetings, it's like when a new drug gets proposed, well, how often have we used it? But that was like dopamine, I think we went through that, right? We dropped dopamine because nobody ever used it, basically. So I think those are important things. So are we moving anywhere closer to electronic PCR throughout the region so we can get real data real time?
Not region-wide, we're not, no. More agencies are coming on board with electronic PCRs, and of course, next year, all the agencies that charge for services will have to have them. But,
say it again, Phil, next year, all agencies will...
All agencies that charge for services have to have electronic data collection by next year. That's the Obama thing, if I'm not mistaken.
And how much of our total EMS is in that category?
In our, the charge for services?
Yeah.
I'd say, that's
run-wise?
Percentage-wise, I don't know.
I would say
run-wise.
run-wise, probably 80%. Not agency-wise, but the ones that are not doing it are the small agencies.
So if you just look at total runs for AAREMS region, you'd say that 80%.
Total runs, I would guess probably 80% are
Our
going to
bill.
be.
Our bill.
Are gonna be
80%
billed,
of
yeah.
visits are runs or
80%
billed.
of the patients seen are billed.
Yeah.
I say that would be fair. That would be fair.
That's amazing. Is that a big shift in the last 10 years?
As far as build,
I mean, New York State at one point was 80% volunteer, all
Well,
EMS.
some of these are volunteers.
Oh, but they're still
because
billing.
Well,
their
we're
agencies can bill.
yeah.
I think we're talking apples and oranges a little bit because 80% of our agencies nationwide, statewide are volunteer, but 80% of the patients are receiving a bill for services. That's not quite the same thing because you have a lot of little agencies that don't generate that much patient activity in the course of the year.
The percentage of agencies are, most of them still are not billing and not using electronic PCRs, but the number of patients seen are highly weighted with the bigger agencies.
More
so-
urban, yeah. Okay. Well, that's good to know. And then all the agencies that are using EPCR, they're all using different software, is that right?
Yeah.
They're using all different ones.
Not all of them, but I mean.
And that comes together with the state, is that right?
Right.
Right, it comes together with the state when they upload to what we call the state bridge.
The data collector from EPCRs has to be NEMSIS compliant. This is coming to a change because it's now going to NEMSIS 3 versus NEMSIS 2, and apparently there's some glitches to be worked out. Of course.
So back to my original question, if the region asked the question, how much midazolam have we used year to date?
They should be able to go up and drill down on that, on the EPCR side.
The EPCR side, yeah.
Yes,
So-
for anybody who's submitting data from the EPCR,
Who should, the state should? or-
Phil should be able to sign on. Phil should be able to sign on to the state bridge, and they have this really neat little side program where you can say how many midazolam, and it'll help you drill down into what you're looking
This
for.
is the
So-
program directors who get access to the bridge?
Program directors
We all
do.
have access to the bridge right now.
We all do?
The program directors do.
Phil does.
So
We
Phil,
do,
can
the
you,
program directors.
can you demo that? Can you show us that? Not now,
Look at this.
but a future REMAC. I think the REMAC, has been, basically had no data ever.
Gus, if you want me to, I can ask. Mike Taylor is the guru, and he loves showing this stuff off.
I was just about to suggest we could get
We
Mike
could get
Taylor
Mike to come
right
out here
and-
for a meeting in
and,
the fall, and he
come
would
on.
gladly show you
Oh, yeah.
how it can benefit you, harm you, etc.
Okay.
He likes to talk.
Good.
He absolutely, I agree with what
Well,
Mary
let's
said.
cut him off at 45 minutes, but,
I would tell them that ahead of time.
Yeah, because 44.
but and the other question I would have is access to the bridge restricted to program directors, or to REMAC directors, or anybody, any physicians, or QI people?
I do not know how that specifically has been delegated, because they're bringing more pieces up, and they've been, over the past year and a half, gradually bringing more programs, like they started with EMS charts, and then ESO, they're bringing up different programs.
Right.
So as more programs are on, I'm not sure if they've expanded who has accessibility.
My understanding, it has something to do with personal background checks and fingerprints and all that kind of stuff, but I wouldn't sway to it.
I think we would pass.
I just wanted to see if anybody laughed at that.
I have access to it.
I mean, I can go on
There,
and,
that
I mean,
tests who can get it.
So Joyce went through it,
I've
not you,
gone.
Phil?
This is a drum I've been beating on at state council, that we have all this data and we're not using it. So I think you guys ought to be making some noise about getting into that data, because there's a lot of it there now, and it would be useful.
The other thing is, you have to be sure that what you're looking for is one of the, whatever number data points that New York State requires is what you're looking for.
Well, but it's huge, and NEMSIS is
Well,
a
it's
huge.
NEMSIS
database.
2.2, I mean, so that's
200
what we
data
could collect on right now.
Right. There's going to be a learning curve, but once you guys get into it, I think it'd be really useful.
Like a medical director that has access, if their agency is EPCR, they can access that, I would assume, right?
our medical director has a sign-in for our data.
Okay, good.
So, I mean,
And
I
only
don't know
your
if he's
data,
ever gone
probably.
in, but,
Yeah.
there's definitely, and not only does he give us access to the data, it's part of the QI system as well.
Right.
Each agency medical director is certainly free to access the state bridge via their own ambulance captain or CEO or whatever, however you want to call the person in charge of the
Right.
service.
So it's analogous, right? So you have an individual agency, an EPCR, and individual medical directors. And then you get to a regional level. You have regional EPC data and a REMAC. It's exactly analogous.
Not necessarily.
Well, I mean, the REMAC
Because here's why. Say GAVAC, are you guys, or even CMT, are you guys sending them through Phil and Joyce, or are you sending them directly to Steve?
Directly to the state.
No,
They're
we
going directly-
upload them to, we don't even send them to Steve anymore, we upload them right to Image Trend.
Yeah, it goes right to the
State.
state.
So it goes right to the data
No, it
bridge.
doesn't go through the region.
No, I'm saying the REMAC would go to the bridge.
Right.
Yeah.
Right.
That's right.
That's
So-
what's analogous.
So it's
about
not,
it.
right, no, I know, but it's slightly, it
One's
depends.
a bigger population.
Correct.
Right.
One's a regional QI function, and one's a...
But the regional QI function may not, unless they go in through the bridge also, they don't receive all the data.
Right. Now, I'm assuming that where we're going with this is that the REMAC QI process will be able to submit queries across the bridge about things that surface that need to be supplied by data.
It's permission levels, is what you're saying. I have permission to look at CMT. He has permission to look at GAVAC, where Phil has permission to look at every agency that is uploading data from the region. So
Every agency in the region I look at.
we come to a point where we need like a data person, so we can say, so the REMAC can turn to the data person and say, we want to ask the following question. Go get the data. We don't all need to be programmers going into the bridge, although we may want to be after Mike Taylor gets done with us. But so I think it's about timeliness of data. I mean, the thing about QI is that historically the state data is just so old as to be useless. So you had guys churning out in 1952 data that we don't know how that corresponds to current activity, right? So you couldn't really
This
take
data
it
is
back.
pretty timely now.
Yeah. So we should get.
And I think that's one of the things that's going to happen as the regions wake up to the fact that they can actually access this data. There will be some way of designating people in the region or the program agency directors or whoever on a consistent basis across the state who can have access to this stuff. So there will be a person to go to.
Right. And then we could perhaps reassure pharmacists or medical directors that we just did a sample. Let's just do a sample of uses of succinylcholine. You got 150 cases year to date. Okay, let's take 30 random and look at those cases. Right. So that would be a useful way to use the data.
Now, is the data that's coming in from the agencies that are not using EPCRs coming into the region, is that going into the state bridge also?
No. Right now, that data is going no place. The paper PCR data for the last 14 months is being stored in each regional office around the state.
Water under the bridge.
They have not. The state has not signed a contract. Now, I am informed. I was going to talk about this afternoon, but Mike Taylor informed us that we had a conference call the other day. Mike Taylor informed us that the contract is almost ready to be signed with FedCap, which is the screener for the paper PCRs.
The prisoner.
And
He told us that 8 months ago, too.
I know. He said it would take place this summer or fall. That's the way he put it. Within the next few months is the way he put it. And when that happens, then the state will ask us to start forwarding our stored paper PCRs down to FedCap. And FedCap's screening process has been altered, and it's being altered now, so I'm advised that, so it's going to be fully NEMSIS compliant, so you won't be looking at apples and oranges. When you look at the state bridge and the FedCap stuff, you'll be looking at oranges and oranges. So we'll be able to make orange juice, not a cocktail.
Joyce, what is the smallest agency in the region in terms of runs per year?
In our region?
Just give me a number. I don't
8.
care.
Oh, 10?
Eight.
8, 10?
The one that's always fighting up one of the lakes up there.
Blue Mountain.
Right,
Yeah, there you go.
Yeah.
8 in a year?
God's honest truth.
Yep.
Yep.
That's what they put on their form, voluntary disclosure.
So they must have barriers to EPCR with 8 runs. And they're not
There are a number of agencies and AAREMS that will never go to EPCRs unless they're absolutely forced to, but because they can't afford it. I mean, there's just no way.
Well, if you're doing 8 runs a year and you're not billing.
Right. And we've got 2 agencies that I can tell you right now that do 8 to 10 runs a year.
2 agencies.
And probably some more.
Yeah, it'd be interesting to look at it.
Well, this is part of my state council report. There is no drop dead date for paper PCRs. There will be paper PCRs available for those small agencies that can't afford, for one reason or another, to go to EPCR. So there will be paper available.
Yeah, Mike Taylor was, I was at a meeting not too long ago with Mike Taylor when he took some pains to announce that there never will be, these were his words now, there never will be a requirement that all non-billing agencies have to go to electronic PCR. He said if you're non-billing, you don't have to go to electronics, and it will never make it. This was his statement.
Never say never. Okay.
Gus, along those same lines, and you'll probably hear about it, Howard helped me out here. REMO's REMAC, or is investigating trying to make the whole region go EPCRs and them expending the money to do so.
Similar to SREMS.
Right. I was at a meeting with Mike Taylor with a rather large municipal agency in the region that basically put the brakes on and said, no way, no how. This is what we planned because of our dispatch system. Our town says we have to do this, this, and this. We don't care what REMO's doing. We'll comply, but we have to use this. And that is perfectly acceptable. You know, you think it's very hard for a REMAC council, et cetera, to force anyone to use a particular.
We would have to get to their medical director individually.
Strong arm tactics behind the barn, I don't know about, but I'm just saying that was, you know, the
Yeah, but the
question was
medical
raised.
directors, I think, would want it, especially if it's a high volume operation.
The conference call that I was on Monday was involved around this. Mike Taylor was obviously trying to get support for region-wide uniformity with electronics, and representatives from all the regions in the state were present on the conference call. The conference call took 2.5 hours almost. There was a wide, as Mary just said, there was a wide consensus among the regions that they didn't want to go region-wide. They just didn't. Some find it acceptable and desirable, and most do not. Most do not.
All right, let's move on.
I think it surprised Mike, too, as a matter of fact.
Stocking and resupply of naloxone, that's an individual pharmacy question?
This is just a discussion. Pat Mangillo spoke with me about this a couple of months ago, and then I spoke with the pharmacist at the pharmacy director at Nathan Latour, and they wondered, the BLS agencies that are going to go to intranasal Narcan, are they going to be supplied through the pharmacy? Is the pharmacy going to be expected to give them the stuff, or just what? And to tell you the truth, I wasn't completely sure. I know that some BLS agencies are getting prescriptions from their medical director and going to the drugstore and getting the Narcan that way. And I passed that information on to Pat and to Bob Stankus and Nathan Latour. But I believe it was Pat Mangillo who said, can you put this on the agenda for just a discussion at the REMAC level.
Are police using naloxone here?
Oh, yes.
Yeah, and there's money for law enforcement to do it, but there's no money.
Where do
for
they get
EMS.
supplied from?
Huh?
They got a grant.
No, but where do they, who supplies them?
They probably contact someone like More Medical and place an
Buy,
order.
they just buy direct?
Yeah, they're probably buying direct. However, we have to be careful of the safe harbor stuff as well when we start talking about resupply. So you can't do it one way for one agency and one way for another agency. If you, and right now, I believe we are, other than a few of us, if we use something, it is being restocked from the hospital pharmacy. So I can't see how we can change how we're doing it for one drug versus all the other drugs that
For
are
the
part
EMS
of
world that we're talking about?
Yeah.
So EpiPen, albuterol, Narcan, all the same kind of approach. So that's maybe how we explain it to the pharmacist. It's just like EpiPen. It's just like,
It's just like any of the ALS drugs either.
albuterol. Right.
And also, as I think was discussed here a couple of months ago at the AAREMS meeting, there are get-togethers around the state touting the versatility and utility of Narcan, where they give out these kits to everybody who's present at the meeting. No prescriptions, no nothing. They just hand them out.
Yeah. It's in the water.
Maybe that's the answer.
Well, it's kind of interesting, because I know my agency, we use one hospital consistently. They do not resupply any of our BLS, our EpiPens, our albuterol, or anything. They don't resupply anything for BLS. We buy that on our own. For the ALS drugs, they resupply them, but they only do it for volunteers. They don't do it for the commercial agencies.
That's the safe harbor part of it.
That's
Yeah.
the safe harbor part of it, yeah.
Right.
But, I mean, you have to, in the safe harbor, you have to treat like groups the same. So every volunteer agency has to be treated the same way by the hospital. Every
Right.
municipal has to be treated the same way. Every commercial has to be treated the same way. So if you have, two commercials, you can't stock one and not stock the other.
Right. Yeah.
How do they get
We just
termed
ran into
safe
the
harbor
commercial
anyway?
agency from Sullivan County came in, and they wanted the drugs, and they said no. Well, why not? Well, because you're a commercial agency, we don't resupply commercial agencies, you're charging a patient, we can't double dip. Well, they do it in other hospitals.
What about the agencies, the volunteer agencies that are charging?
We don't have any volunteer agencies that are charging.
You don't install?
Nope,
No.
they don't.
Nope.
But there are.
There are some around, yeah.
See, if you're a
But
member
I-
of a
but
fire
it doesn't-
department, if you're a member of a fire department based ambulance right now, volunteer fire department based ambulance, you can't charge.
But the safe harbor has nothing to do with whether you charge or not.
Right.
It has to do with types, groups, and types. It has nothing to do with whether or not you charge. So the question comes down is, can you treat, within that, can you treat different medications differently?
You can't.
And I would think that if you say you're going to resupply, that means you're going to resupply.
So I guess, you know, if I get asked by a pharmacist what they should do about naloxone, I would say, what do you do about albuterol? If they don't resupply albuterol to BLS agencies, all right, well then, I guess you don't do naloxone either. So you write a script that you do other means, sounds like. Does that ring true? Okay, good, I'm ready for that question. Is Fox asking that question? Did you say this came from Fox?
Yeah, it came to general discussion with Pat Mangello a couple of months ago, actually, now.
Okay.
And he said he would welcome a little thought on the subject, a little discussion.
Okay.
And ironically, I think the reason you weren't at the May meeting, Gus, was because you were at a meeting with Pat Mangello and some of the other pharmacy folks about suppliers.
Oh, it was both Senator Seward's voting on
Yeah.
heroin.
Right.
A lot of us were at that, yeah.
I think that's what it was, right? Is that the conference?
Yeah.
All right, any other new business?
I would like, we had and I'll report on it this afternoon, and Maggie Wilson was there too, and she will too. We had an excellent meeting at GAVAC with Dean Romano from REMAC, talking about the electronic system of tech reporting of their updates during the year. And I would like the REMAC physician's permission to continue looking into this with a view toward adopting a version of the REMO system to make it a bit more user-friendly for the techs and the agencies, particularly the smaller agencies, actually. The larger agencies now are advising me with just a single letter and all the names on it and so forth, but REMO has an excellent electronic system, and I've only just begun to look into it, but Dean Romano has been very generous at letting me access it on the computer. And I would like permission to continue developing this with a view toward the REMAC adopting it. And I will keep the REMAC members and physicians advised over the summer, and possibly we can have it adopted by our September meeting.
That sounds good. I mean, the more congruence we can have with other regions, I think is a good idea.
Did you say something about, it depends on how much it costs? Was it the software?
Dean wasn't sure about the cost, if there was going to be any.
Okay.
He was a little bit indefinite about that, and he and I have had other fish to fry since then, so we haven't had too many discussions since our meeting, but he said there was some kind of a cost because Remo uses a remote server, so they, my experience with fees for use of a remote server are that they're fairly reasonable. I'll keep everybody advised, however. Obviously, I'm not going to spend anything without permission.
All right. Correspondence is for executive session, I guess.
We have a little issue in executive session.
Okay. Old business, any new protocol feedback? What is the collaborative protocol up for a redo?
They're redoing as we speak.
Okay.
There is a group, Howard and I have been in and out with it, but they are striving to have a redo of our current and adding the AEMT protocols, ready to go to CMAC in the September meeting for a January 1, 2015 implementation.
All right, so they're targeting January for approval?
No, September for approval, January for implementation.
I would highly recommend that if anybody in this room is interested in looking at the draft, that you contact Dr. Daly ASAP.
Are they floating a draft electronically?
Yeah.
They are?
Yeah.
They
Can
have.
we get it through our website?
They've only released it within the committee.
Within the committee at this point.
Dr. Daly would not be adverse to someone looking at it.
Yeah, I think we should, you know,
At the last REMAC meeting, Dr. Daly opened up to anybody who was interested to contact him to join the group. So I would think that that would stand for anybody here also.
I'll do it.
I have a question for you on that. Is the AEMT program, and I understand it's a national program, but is New York changing that in any way?
They are supplementing it. Have not been removing, they've been supplementing in just a few areas.
So yes, it's been changed. If you look online on the state DOH website for the transition page, it really provides you the AEMT education standards, and that's a great way to really look through it and see the nuts and bolts of what's in there. So two of the nice things that the national model doesn't have, that the state model does, is IV cardiac epi and cardiac arrest, so 1 to 10,000 epi, and intubation. I'm teaching a class right now. I'm actually the IC, and I gotta tell you, I love it. I think it's a great level, and I think it's gonna be a nice supplemental level for both rural volunteer agencies that are trying to get ALS out there and are having trouble meeting higher education training standards to get done. And I think it'd be great to supplement other crews that are either commercial or paid or even paramedic crews.
all right, so just to facilitate protocol feedback, Phil, if you could just get the link out, if Dr. Daly is permissive, to the most recent draft of the...
Sure, I will do that.
Just to notify everybody, and it's in my report, which I'll hand out later. We made a change in medical standards and CMAC, which SEMSCO approved. The lower blood glucose level now is 60 instead of 80 for adults and pediatrics.
Okay.
Effective immediately.
Right.
But what trumps what?
60 trumps 80.
60 trumps region, state trumps region, or region trumps state?
State trumps region.
State trumps region?
Oh, really?
Well, you asked, so.
State trumps region on a BLS level.
Right, but what about ALS providers?
Right,
That's
why
my
I said it that way.
ALS regional protocols.
It's changed BLS and ALS.
So if you're
Regional protocols, I didn't get a change from the region.
I would highly recommend that we follow the state guidance and approve.
There you go.
Thank you.
There you go.
All right, any other business before we head into some kind of executive session? Any other comments?
I know I always say this, but the executive session shouldn't take long at all, but I think we can go right next to it.
Heard that before.
I know, I've heard it from me.